So now I would like to focus your attention on our great expert who will be sharing their long time knowledge and expertise on inducible urticarias, Dr. Iman Nasr. And please be active, be attentive, and I really hope we'll receive a lot of your questions. And Dr. Iman, please proceed, and I hope you have a great presentation.
Right, thank you very much, Aistė, for this kind introduction. Thank you all for being here, joining us in this great session. So, what are inducible urticarias? What tests are performed and how to diagnose them? I'm Dr. Iman Nasr, consultant immunologist and allergist at Royal Hospital, Oman. So I'll start with what is urticaria for those who are joining us newly. So urticaria is itchy wheals, or angioedema, which is a swelling, or both. So what is a wheal? The wheal, as you can see from this photo, it is a rash, a type of rash. It is elevated, means you can feel it when you touch it, red, but can be white at the beginning, short-lived, so it stays for a couple of hours, and it's itchy. You want to rub it. As for the angioedema, or the swelling which is under the skin, it feels and looks bigger than normal. It is again short-lived, so hours to a few days. And it's very important to know that it's not dangerous when it comes to spontaneous or inducible urticarias usually. So it involves the lips, eyes, hands and feet, and tongue. The feel and look may vary. They could be itchy, painful to some, not painful to others. It may be red or skin-colored. So what are these urticarias? It's a broad spectrum, and we define the urticarias into spontaneous urticaria and inducible urticarias. So we will focus on inducible urticaria, but very quickly to touch a bit on the spontaneous urticaria from its name, spontaneous. So some certain cells which we call mast cells, which are present under the skin or even in the vessels, they just burst. And it could be to a known cause, such as some infections or some autoimmune conditions, rheumatic conditions, for example, or it could be to unknown cause. So some reason you may wake up, or someone may wake up with this rash, wheals over the entire body, or swelling of the eye or the face with no apparent cause for this. And the other spectrum which we'll be talking here is the inducible urticarias. Probably some of you have experienced where you can just scratch your skin and you see this red line where you can write your name or write anything there, which we call symptomatic dermographism or physical urticaria, one of these physical urticarias, or maybe when you're exposed to the cold or by pressure, wearing a tight belt or a bra, then you end up with a line of redness and maybe a bit of swelling, elevated, maybe some heat or vibration can trigger the itching and the angioedema. So these are the physical urticarias. We also have cholinergic, such as sweat, or contact urticaria, aquagenic if it's exposed to water, for example. Now, 20 to 30% of all the chronic urticarias, which is urticaria that comes and goes for more than 6 weeks, are inducible. When we say inducible, as I mentioned, these are itchy wheals, angioedema, or both. They are brought about only on exposure to specific physical or environmental stimuli or non-physical. So cold, heat, exercise, pressure, sunlight, vibration, water. So physical urticaria and non-physical urticaria. Just to recap, so physical urticarias is the largest group of these inducible urticarias, where symptoms are triggered by physical stimulation on the skin, like rubbing, pressure, cold, heat, sunlight, all these physical stimuli or environmental. It can be non-physical urticaria, which means sweating or contact or even water. Now, these inducible urticarias, they can occur alone, or they may be associated with other forms of inducible. Some patients might have delayed pressure urticaria and might have, for example, cold urticaria or heat urticaria, or maybe cholinergic by sweat. Some inducible urticarias may occur with a spontaneous urticaria. So the patient might have spontaneous urticaria, the rash, wheals, angioedema, just breaks for no reason. But also when this patient is exposed to any other physical stimuli, for example, pressure, delayed pressure, or usually dermographism, they would have it together. So this is how it looks in the first two here. We have the symptomatic dermographism. This is skin writing, dermographism, solar urticaria or heat urticaria. We have cold urticaria. Here's the pressure or delayed pressure urticaria, and vibratory, caused by vibrating machines. So how do we diagnose these urticarias? Very important is history. So we sit with the patient and we try to understand the time of onset of the disease. How frequent? How long does it last for? What are the provoking factors, the triggering factors? Any fever, any constitutional symptoms, joint aches or pains that might point towards some autoimmune disease, thyroid disease, for some known causes. And then we embark on physical examination, and it's tailored to the history. And we have lots of diagnostic provocation tests. So these are physical tests that are performed in order to diagnose various types of inducible urticarias. So why do I say provocation tests? So these are tests that actually performed on the patient, depending on what we are suspecting, in order to produce the symptoms. So we are provoking our, simulating the environment for which the urticarias are produced. And then comes the threshold test protocols, where we see to what degree do these symptoms start. So these are the various diagnostic provocation tests that Stefanie will elaborate on. So we have for the cold and heat urticaria something called the TEMP test. We have the dermographometer or the Frick test for the dermographism. We have a UV, visible light projector, for solar urticarias, delayed pressure test. We have for the delayed pressure urticaria, where we apply pressure and see if that elicits symptoms. We have the vortex vibrator. So for those patients who have symptoms with vibration, ergometry test for those patients who may have symptoms on exercise or sweat. So TEMP test again, cold urticaria and heat. This is where the patient applies the volar aspect of the forearm, and we see at which temperature do the wheals or the swellings develop. We could use an ice cube test. So it is placed an ice cube in a plastic bag, and we wait for 10 minutes so we can read the wheel size. And this is done in centers where they do not have the TEMP test. The Frick test, symptomatic dermographism, 4 pins of varying lengths, where we rub against the skin, make a scratch on the skin, and we look into the lines at which, how many lines did the wheels appear on. Delayed pressure urticaria, the US visible light projector for solar urticaria. Now, how long will I have it for? This is a very common question we get. Now, we know that it takes longer than chronic spontaneous urticaria, but the good news is it will eventually go away. The most important is avoidance of trigger as much as possible. We do understand that it's not always possible to avoid the trigger, but avoidance as much as possible. And there are treatments. So we continue to treat until symptoms are controlled. we keep on treating until the disease goes away by its own or on itself. So we use antihistamines from 1 tablet, and we go on to 4 tablets a day based on your urticariologist, and some other medications such as omalizumab, which is present in many countries, where it's given as 4 weekly injections. So thank you all very much. I'm open to your questions.
Thank you, Dr. Iman, very much. It was very interesting presentation, and we already have the first question. So I know that we will talk a little bit more about the provocation test, but I would like to ask you more about the laboratory work. What do we do when we have the patient with inducible urticaria? What markers do we investigate, and whether there is a specific marker that would tell us that this is actually an inducible urticaria?
So this is a very good question. So yes, sometimes we do the blood tests to differentiate what type of urticaria. And as I said, although physical urticarias can be present, but it's very important for us to know whether there are any associated chronic spontaneous urticarias, or if there is something provoking the urticaria in general. So we perform a lot of, well, not many blood tests, but it's very important to see the blood count, the kidney, the liver function. We look at the level of an antibody, which we call IgE antibody. This helps us to decide on how fast will the patient respond. We also do some thyroid function tests. So it's the thyroid gland, to see the activity. It can be associated with chronic spontaneous urticaria. And depending on the patient history, we could do even further tests. So if there is a question about infections, we do some battery of infection tests for that. If we are thinking of autoimmune, we would go to that line and test for those as well.
Perfect, thank you very much. And I believe that for quite a few patients who first time in their life develop urticaria, it's a little bit scary. It's unclear what the diagnosis is. So probably the first question that patients ask you, is it dangerous? Is it life-threatening? And is there a sort of urticaria that is actually life-threatening?
It's also a very good question. So this is why I mentioned in the majority of cases, it's not life-threatening, with the exception of cold urticaria and probably exercise-induced urticaria. So in cold urticaria, we always just make sure and we educate the patient that not to jump, for example, in cold pools. It may go on and induce anaphylaxis, which is a very serious condition where the patient might, have a very severe systemic reaction with a difficulty breathing, drop in blood pressure, and probably a throat closure, for which we advise an adrenaline auto-injector in such patients, as well as exercise-induced urticaria, which is where the patient might be exercising vigorously and might end up developing very severe reactions leading to the life-threatening. So these are two exceptions for this. And this is why we are providing those webinars, so that they do visit urticariologists, a UCARE center near them, because these are the centers who do understand very well these conditions and which ones would require special attention in regards to treatment. So again, an adrenaline auto-injector if the patient has the exercise-induced urticaria, to be kept with them at all times.
Thank you very much. And you have just mentioned very briefly the cold urticaria. So if going a little bit deeper into this specific topic, would you recommend to do a more extensive testing, laboratory testing on these patients? And would you recommend checking the cryoglobulins and cryoglutinins in these type of patients?
So in some patients with cold urticaria, there are very few cases where they may have associated familial tendencies for developing. So yes, in some patients, we may go along and test for those, especially for those who you are suspecting a like the familial cold urticarias.
Thank you very much. And final question for now would be about the total IgE count in the blood test. You've already mentioned that this is the thing that we look into, and we expect usually a certain concentration of IgE. But some patients do have a normal range of IgE. Is that common? Is that normal? Is it acceptable? Or is more an exception? And how then it would be explained?
Right. So yes, there are patients who may have a very a normal IgE, and usually it's not the high IgE as such. It is usually within the normal range. It helps us very much to see who are the fast responders or those who will respond to antihistamines and maybe omalizumab as well. So it is very helpful in order to predict responses. And it comes into even more help when initiating a treatment such as omalizumab, where after 4 weeks of treatment, we tend to measure the IgE levels again. And if they doubled, so they increased, this is a good sign that the patient most likely will respond to this treatment. So it is good when the IgE is not really very low. I'm not saying that it's bad when the IgE is low, but probably it needs more work and follow-up and a bit of a more physician-patient bonding, let's say, in terms of managing symptoms more aggressively.
Okay, I told you this was the last question, but just the small clarification for our audience about the IgE itself. We talked a little bit about it, but maybe just to know, getting back to the beginning, what this IgE is, what it does, what it is responsible for, since it's already playing such a huge role.
Right. So the IgE is basically an antibody in the human body, where it is proposed to have an effect on the development of urticaria, not solely, but it has an effect. These antibodies sit on your special cells, which are called mast cells, and help it to burst and release all this histamine causing the itch and the wheals. So we try either to make and we've got lots of receptors, of course. One of them, as we say, is these antibodies, the IgE, and it could be associated with allergies and fighting parasitic infections, etc. But in urticaria, these are the antibodies that sit on your mast cells, causing them to burst, degranulate, releasing all the histamines and causing the annoying itch and wheals. And when it's a little raised in the blood, this means that most likely it's a favorable response to some medications that target the IgE or binds to these IgEs.
Thank you very much. I'm happy to see all your questions flowing. Keep doing that. But now I would like to give the floor to Stefanie, who will tell us more about the provocation itself, about the characteristics and how do we perform, what is it important to note and to focus your attention before, during, and after these provocation tests.